name is Stephanie Moss. I'm a fourth-year medical student studying in Chicago, and I'm going to talk a little bit about the different health conditions that I suffer, that I actually found out I suffered through medical school. So first thing, I was a second-year medical student going through, as we normally do, all those book exams, reading, and we were specifically in the sex and reproduction block. And as we were going through, I was using our first aid textbook, and I was just going through the different women's health pain conditions, and different symptoms started to like ring in my bell of, that sounds familiar. That sounds really familiar. Wait, that's not normal. That's like a problem. I thought everyone had that. And so different symptoms started to come like that, that I started to realize that these were actually conditions, that different things that I was experiencing were not normal. Having long periods, painful periods that would last days, and full body pains going to the bathrooms, pain during sex, all these different pain conditions I thought was normal. I thought pain was just a part of life. I had previously gone to an OB-GYN when I was little, and kind of was like told like, oh yeah, that is normal. All teenagers have pain, you'll get over it. One time I was recommended birth control pills, but my family didn't want me to be on them. So that was kind of it. And then in college, I went to a couple other doctors for my different stomach pain conditions, and again was ignored and just told, oh, it's anxiety. Oh, it's, at one time I found out I did have stomach ulcers. So okay, I kind of chalked it up to stomach ulcers. But again, here was these conditions now in a textbook. I'm a second-year medical student. So I'm like, okay, I have a really good health insurance now through my medical school. Let me check this out, because I'm starting to get pretty nervous about this. So I go to my primary care doctor that they assign in medical school. And once again, I'm told, oh no, you're just a medical student. Every single medical student comes in here saying they have tons of different conditions because they see them in your textbooks or you learn about them in class. So I was just like pushed away of, don't worry about it. But I kept worrying about it. And this time I decided to get a second opinion and actually go to a professional. Granted, it was many months later that I finally got in, but only through my connections with the medical school did I have that opportunity, that privilege to go to a specialist who is trained in endometriosis. And I remember walking in there and I was so nervous. I was sweating, my heart was beating out of my chest. I'm like, oh no, is this a mistake? It was the other doctor, right? Was I just a medical student? Was I just faking it? And amazingly, this specialty doctor, she sat down, she listened to me, she's like, that sounds like endometriosis. What do you want to actually find out? Like, do you want to go through the surgery? And I was just blown away. I was like, wow, someone's actually listening to me, that this is not normal, that this could be something and we could actually do something. So a couple weeks later, I went in at my medical school. We had a Da Vinci, which was super cool at the time because there were two of the hospitals in Chicago who had Da Vinci machines. Granted, we have a lot more now, but yeah, I went through and the doctor did a fluoroscopy where they put in this kind of green fluid, and they turn off the lights and they can actually see where there's more blood flow. It's kind of things that are more green. And she went in, she cut out those pieces and sent it to pathology. While she was also in there, she did look for the typical things that we look for in endometriosis, like endometriomas, like massive big chocolate cysts. Those are the typical things we hear about in the medical school curriculum or in the textbooks. I thankfully didn't have those, so we went on. She did find a hole in my pouch of Douglas, which found out later that was a typical thing for endometriosis patients. but only a doctor that kind of sees a lot of different patients, a lot of different types of endometriosis would be able to see that. While she was in there, she also did something special. She actually went through and she checked my fallopian tubes to see if they were clogged, because she said that a lot of her patients kind of don't look at their fallopian tubes until they want children, but she thought it might be helpful. And I'm so glad she did, because when I came out of that surgery, even though it was painful and it didn't really help too much in regards to like helping pain, what it did do is it really helped to solidify that, yes, I do have endometriosis, and something new that I hadn't even thought about. I had infertility. My tubes were clogged they were fibrosed. And so that brought me into a whole nother journey of infertility as a second-year medical student. And I really became more aware and started to go in to see kind of what this community looked like for individuals with endometriosis, individuals with pelvic pain, individuals with infertility, and kind of see like what's out there. And it really surprised me how many individuals struggle with this condition. 1 in 10 individuals who have a uterus, not just women's, not just cisgender women, anyone with a uterus could have endometriosis. 1 in 10. And then when we look about infertility, about 50% of them end up having some sort of infertility problems. Now, that is just crazy. And apparently my story isn't that unique. The majority of individuals with endometriosis take many years to get diagnosed because we're not trained as medical professionals to really catch these as teenagers and young 20s. We wait until they struggle with infertility, or we wait till they've seen many practitioners to actually give them a diagnosis. It ends up being almost a diagnosis of exclusion instead of actually being aware and noticing it. Big thing is that not just OB-GYNs are the ones seeing individuals with endometriosis. We have primary care providers, gastroenterologists, urogynecologists, urologists, psychologists, psychiatrists. These individuals with endometriosis are seen by so many types of doctors. So it's not just the sexual organs that are problem. This can go all over your body and affects the entire body. And so that's why it's such a struggle for individuals to be treated, because we think that it's just one type of condition, that it really affects the entire body. And I really want to encourage other physicians to really kind of think of it as a whole body disease, because this is a chronic long-term health condition. Like I said, it very commonly impacts the gastrointestinal tract. So it's found a lot of people with endometriosis also have IBS. A lot of them also struggle with urological conditions like urinary incontinence, urinary pain. So they see their urologist, but they're always separated. This really needs to be a collaborative approach to be able to treat and take care of these individuals. So going into that, let's look at all the types of doctors an individual must see. So we talked about the OB-GYN, usually is that, most likely a fertility doctor at some point. So that's 2 urologists, that's 3 gastroenterologists or rectal surgeon, that's 4 or 5. Primary care doctors, 6, psychologists, 7, psychiatrists maybe, because there's a huge correlation with just stress and trauma in endometriosis. So already that's 8. And then you have to think of all the other therapists. In addition to psychotherapists, you have pelvic pain. You have tons of pelvic pain, and stomach pain and leg pain and back pain. So pelvic pain, physical therapists and just physical therapists, occupational therapists. So many doctors and health providers see this type of condition. And so it's really important that we really recognize that there's a lot going on with these individuals. And it's really, as I've gotten more connected with other patients similar to me that are struggling, it's really sad how much there is a kind of the distrust in the health profession because they've been ignored for so long. We really need to take charge of this and really help these individuals see that, okay, maybe we ignored them in the past, but we're going to help them through this and not just ignore their pain. This includes also, if you are a student, look at being a primary care provider that treats individuals with these pains, because like right now, I have to act as a primary care provider for myself and have to do a lot of the referrals, a lot of the management of all my medications, all my treatments and everything. So it'd be really beneficial to have primary care providers that are excited and interested to be able to take care of 10% of individuals have this condition. Let me see. I also wanted to talk a little bit about accommodations, and because this is something that I started to really start considering when I went into medical school. Because once I had to, take time for my surgery, take time for the recovery, take time for all these doctor's appointments, especially once I was diagnosed and once I could actually start treatment. And unfortunately, in the medical profession, we don't like to talk about it's seen as a weakness to have a health problem. And so that was a big thing that I've been trying to advocate for, is the acknowledgement of what it means to get accommodations and to get help from the school, from the hospital, from the clinic. And it's not that much. Maybe it means allowing you to have a chair to sit down, because pain sometimes can come out of nowhere and it can be severe. So maybe having a chair during rounds if you're in the hospital, or sitting down if you're in surgery, if it's surgery clinical rotation. Having access to a bathroom is huge. Like I said, pain and having IBS symptoms, pain and gastrointestinal and neurological problems can come really quick. So you need to address them when you feel the need to go. So having bathroom breaks, and those two things are really helpful, and unfortunately are not seen to be not a normal thing. And so if a student or a health professional realizes that they need it, they can go to the disability office, or they come to get an actual accommodation, a letter that says, I have a medical condition, I need to sit more, or I need to have access to the bathroom. You don't need to say what type of health condition you have, just needs it. And thankfully, when I actually have gotten that accommodation and have actually opened up to my supervisors or my residents or attending and say, like, hey, I have a medical condition, I have to sit, they're fine with it. It's so interesting when you're open and you just say that, people are more okay with it, versus maybe if you just sit or you escape to go to the bathroom. There's this concept in medicine maybe that you're unprofessional or lazy. So to prevent them from thinking that negative, it might be helpful to have that open communication with them. An additional accommodation the individuals with this condition might need is the flexibility to go to doctor and therapy appointments. Could be once, twice a week. Maybe they're virtual, maybe they're in person, but we need to have those breaks to have those health conditions to care for our conditions. Same thing with set times open where you don't have a pager, you don't have to attend to a patient, so you can take your medicine and you can address your flare. That's super important and is definitely a struggle that a lot of us deal with. I know when I was doing my clerkship rotations, I tried really hard to push through some of the days I would get flares. And even though I pushed through, I was doing all the things that I was supposed to. I had my NSAIDs, I had my heating pads, I was sitting down, trying to limit as much movement as possible. I just had to, there was a time that it just became so painful. I just had to go home to go rest for a couple of hours. And it was hard, but eventually I learned that it's okay to be able to do that. But it was a difficult step to be able to stand up for myself and be able to say, no, I cannot go in, or to be able to text my residents or my team like, hey, I'm having a flare. Don't have to say what is, or I can't come in until this afternoon. Sometimes my flares only last a couple hours and then they're good. Let's see, so that was accommodations. Looking at, I talked a little bit about pain management strategy. I know in our good old first aid books or in just education on endometriosis, a lot of the treatments they say is just NSAIDs, pain pills. But what we forget is a lot of those pain pills, if we can have them, can really affect our liver if it's Tylenol, or really affect our stomach lining and cause ulcers if they're ibuprofen. And so it's important to really, as health providers, encourage patients to have to go to pelvic floor physical therapy, to be encouraged, or go to, I forgot PM&R, that's a really great specialist that really works a lot with pelvic pain and endometriosis. And so like some of the other types of pain management strategies that are recommended includes TENS units that can provide like pulsation or massaging on the stomach or abdomen, heating pads, baths, pelvic wands, abdominal fascia massages, constipation diets, and just there's so much out there. And so we really need to remember it's a full body disease, and there's so many types of specialists that people with endometriosis have to work with. So it would be, I look forward to a time where we have a holistic interprofessional work to really support other patients like me. That way they can really live successfully with this chronic pain condition. And I'm very lucky that I'm a fourth-year medical student. I'm trying for my residency. Hopefully I'll continue on. But unfortunately, I've also met a lot of patients that have given up, that have been so overburdened with their health condition that they've struggled significantly with work. And I think we can do a lot to support them, because everyone is different. Some people have no pain, don't know they have endometriosis until maybe they want to have children, or just randomly during another surgery. And then some people can have a lot of pain. We're still trying to understand this health condition, this over-inflammatory condition. So I look forward to more research, and I look forward to learning more as we continue to learn about this condition. Oh, one more thing. It is not just a endometriosis used to be called the white woman's worker syndrome, because they were only white workers, high achieving women. We used to call it that because that's who we diagnosed them, because that's who had the affluence to be able to get those specialists. And so that's now led to Black and Hispanic women to be underdiagnosed with this condition. So just another plug-in, a reason why we should really look for it in all our patients who are struggling with pelvic pain, and not just tell them it's normal. Actually follow up and see if there's other things it could be. So thank you so much. If you have any other questions for me, you can check out my website, medpsychmos.com. I have a lot of resources and for other patients with endometriosis and pelvic pain conditions. As I learn about them myself, I add to them. I'm also an advocate, part of the advocacy committee for ISHWISH, which is the International Society of Study of Women's Sexual Health, which we're also advocating for recognizing the different sexual health conditions in individuals across both the gender and racial sphere. So thank you very much.